Hello everyone, this is Dr. Aparna, Neonatologist, KIMS Cuddles, Kondapur, Hyderabad, and we are going to discuss today's video on OSCEs in statistics and some OSCEs in fetal medicine and prenatal diagnostics. These two are very important areas for the MD or DNB Pediatrics exam and very MCQ rich area as well. So you can be asked multiple questions in statistics either in your theory paper or in the form of OSCEs. So the first question, the first part is going to be on statistics. Now name this curve and define the x-axis and y-axis. So this curve is something called as ROC curve, receiver operator characteristics curve. So this is a curve that is used to understand or identify the discriminating ability of a diagnostic test, or you could say diagnostic accuracy of any new diagnostic test. So for example, if you're evaluating the role of say C-reactive protein, CRP, in diagnosing neonatal sepsis and you're comparing it with the standard, which is blood culture, then you would have, of course, sensitivity and specificity for the test, the new test that is being used, which is CRP. But another way of making sense of this new test's diagnostic power is to look at the ROC curve, which is the receiver operator characteristics curve. So what exactly are the x and y axis in the curve? So the x axis that is here, it basically represents the false positivity rate, that is 1 minus specificity. And the y-axis of the ROC curve represents the sensitivity or the true positivity rate. So it's true positivity rate in the y-axis and the false positivity rate in the x-axis. So if you have different cutoffs of the test, so let us say CRP, we can perform at a cutoff of 0.5 milligrams per deciliter. It might have a certain sensitivity and a certain specificity. So which you are going to say, let's say plot at it will be somewhere here, because the sensitivity will be higher, the specificity might not be that good. So 1 minus specificity is going to be relatively high. If we have a different cutoff of CRP, let's say we take a cutoff of 1 milligram per deciliter, you are going to have a different sensitivity and a specificity. So if you plot sensitivities and specificities at different cutoffs of the same test, you get a curve, and that actually helps us to get the ROC curve of a certain diagnostic test. Now how this curve helps is, one is from the slope of this curve. So if you have slope of any particular curve, it is nothing but the y-axis by the x-axis, which is nothing but, in this case, it is true positivity rate divided by the false positivity rate. This gives us the likelihood ratio of a positive test. So the slope of the ROC curve gives us the likelihood ratio of positive test, the formula for which is true positivity rate divided by the false positivity rate. So getting a positive test increases the likelihood of the patient having the condition by how many times? That gives you the likelihood ratio. So if I have a likelihood ratio of, let's say, 3, it means that a person or a patient having test positive or CRP positive is 3 times more likely to be suffering from the condition, which is neonatal sepsis, as against not having the condition. The other thing which we infer from the ROC curve is something called as the area under the ROC curve. So this whole area under the ROC curve, it's called as AUROC. And AUROC is an excellent way of identifying the discriminating ability of a diagnostic test. So the greater the AUROC, the better is the discriminating ability of the test. So usually having a AUROC of around 0.5 is considered to be a weak discriminating ability, because it is as good as tossing a coin. So doing the test is like tossing the coin. So if heads versus tails, you have a probability of this being true disease versus not truly deceased. Now, on the other hand, if the AUROC is closer to 0.9, so 0.9 is considered to be a cutoff for defining a test with excellent discriminative ability. If it is between 0.7 to 0.9, it is supposed to be good. Anything between 0.5 to 0.7 is considered to be an average, or not a great test for determining whether the patient is deceased or not. So AUROC, the greater it is, the better is the discriminating ability of the test, And this is a curve in which the x-axis represents false positivity rate, which is 1 minus specificity, and the y-axis is true positivity rate or sensitivity. So this was about the AUROC. The other thing which we can also use this for is to compare two different tests. Now, let us take an example. Supposing you have two different diagnostic tests for sepsis. So you have CRP and procalcitonin. So one way of looking at the relative diagnostic potentials or the discriminating powers of these two tests is to compare their area under the ROC curve. So when we look at various diagnostic parameters, variables of a diagnostic test, one test, say CRP, may have better sensitivity at a certain cutoff, whereas procalcitonin may have another advantage, but it might fare low on another parameter. For example, if you take C-reactive protein, in general, it has good sensitivity or good negative predictive value, but it may have poor specificity. So CRP may often come positive in non-septic conditions as well. Whereas procalcitonin might have some other advantage. It might be fairly specific because there may be fewer non-infective conditions which cause PCT elevation, but it may have another problem. So in order to put this all into a summary parameter or one final parameter, AUROC is very, very useful. So if you have a test that has a better area under the receiver operator characteristics curve, then you can easily infer based on this one information that the test has a better discriminating ability. So it is also very useful for comparison of two tests. Not only for diagnostic power, you also use this AUROC in the context of prognostic tests. So if you have a parameter that helps us in outcome prognostication, even in that context, we can use the AUROC. For example, let us say various tests done to identify a newborn who will develop significant or severe hyperbilirubinemia. So let us say you have various parameters like the cord bilirubin value. Cord bilirubin, you might have the N-tidal carbon monoxide level, which is a test, which is a gas that is produced as a byproduct of bilirubin metabolism. You may have other parameters like the pre-discharge, TCB level, transcutaneous bilirubin. So let's say I want to compare all these tests in predicting the occurrence of severe hyperbilirubinemia. So, each of these tests will come with their own AUROC. So you can compare their predictive ability using the AUROC. So the other purpose of the AUROC curve is also to choose an appropriate cutoff where the test has the best possible sensitivity and specificity. So this is another utility of the receiver operator characteristics curve. So we move on to the next question. So what plot is this? Name the plot. What type of variables are used on the x and the y axis? And what does a dotted line and point A represent? So this plot is called as a scatter plot. Scatter plot is a statistical figure that is used to assess the correlation between two parameters. So when we talk of correlation, what do we understand? How do two different variables correlate with each other? For example, gestational age in weeks and the birth weight in grams. How do they vary with each other? Now usually when gestational age in weeks increases, we expect the birth weight in grams to also go up. But this might not be a perfect correlation because sometimes you know that in IUGR infants, the birth weight doesn't necessarily increase with increasing gestational age because of uteroplacental insufficiency. But in general, the relationship between these two parameters is directly proportional. So when one increases, the other one increases. So in those scenarios, you get a plot that looks like this. Whereas when you have some variables where one parameter increases, the other one might actually come down. So then that relationship is going to look like this. So the direction of scatter plot helps us to understand how two variables are related to each other, how they correlate with each other. So correlation is usually used in the context of two continuous variables. So obviously you cannot have a categorical variable like a yes or no sort of variable in one of these axes. So both the variables should be continuous variables. By continuous variables, we mean these are numerical variables which can permit the presence of a decimal point. So these are numerical variables and they could have a decimal point. Now the dotted line that we see is the line of best fit. So in a scatter plot, when you have maximum number of variables falling in a certain line, it gives us the line of best fit. So that represents the correlation in majority of the values. So if you have a point that lies outside this line of best fit, it is called as an outlier. So like we saw in the previous graph. So if you see, majority of the variables are lying here. So this is the line of best fit. So any variable which is lying outside this line of best fit is represented as an outlier. So what is the use of scatter plots? Scatter plots are useful for assessing either positive or negative correlation. So positive correlation is when one parameter increases, the other parameter also increases. Whereas when one parameter increases, if the other parameter decreases, the line of best fit is going to look in this direction. And you also look at the clustering effect, where you see the maximum correlation and you can identify the outliers. So this is another example of two continuous variables. One is the gestational age in weeks, the other one is birth weight in grams. So if you have a data set that looks like this, you can use you can use a scatter plot to understand their correlation. Other examples would be blood urea nitrogen and serum creatinine levels. You can have BMI and maybe something like serum cholesterol levels. Okay, so these are all different parameters to understand the correlation. Okay, we move on to the next question. Name this graphical representation. What do the rectangles, the horizontal lines, the rhombus or diamond and the vertical line indicate? So this is the vertical line they are talking about, the central line. Okay, so this graphical representation is nothing but a forest plot. A forest plot lies at the heart of any meta-analysis or a systematic review. You all know that a meta-analysis is considered to be the highest level of evidence when it comes to synthesizing, interpreting various studies and drawing meaningful conclusions to make guidelines of implementation or guidelines of action. Systematic review stands at the highest level of the evidence pyramid. So you have evidence pyramid or triangle, where you have starting from individual case studies, case series, you have expert opinions, and going above that you have all the observational studies like case control cohort studies. Then you have the interventional studies like randomized controlled trials. So properly conducted blinded RCTs will be standing at a much higher value than the observational studies. And right at the top of the pyramid, you have the systematic review or meta-analysis, which indicates a sum total or a summary of various randomized controlled trials published comparing an intervention versus control, and tries to provide the pooled effect of the intervention on the outcome of interest. Usually systematic reviews include only the interventional studies like randomized controlled trials, but occasionally you may have systematic reviews of observational studies as well, or you may have combinations of randomized controlled trials and observational studies. So this graphical representation is the forest plot, and the forest plot has various parts. So let's go by segment by segment. So on the left side, you have various studies that are mentioned, the names of the authors and the years of publication. Then you have the intervention arm. So this forest plot seems to be comparing trophic feeding versus fasting on the outcome, which looks like probably NEC, necrotizing enterocolitis. It's not mentioned here, but the outcome is NEC. So you have the intervention arm in each of these studies. So you have the denominators. So for example, in the first study, 8 by 96 developed the outcome. So 96 were the total number of patients in the trophic feeding arm, out of which 8 developed the outcome, which is NEC. The next group is the enteral fasting, that is the placebo group, where in the first study we had 94 total participants and 6 of them developed NEC. So this would be provided in each of these studies in the second and the third column respectively. So you have the total number of participants and the number of participants who developed the outcome. And then you find the sum total of the total number of participants in the intervention group, total participants in the control group, in all the randomized controlled studies that have been included in this meta-analysis. Then you have the risk ratio of each study. So each of these rectangles here represents the risk ratio in the individual studies. And as you all know, relative risk or risk ratio represents the ratio between the incidence of the outcome in the exposed. So, incidence of the outcome in the exposed group divided by incidence of the outcome in the non-exposed group. Now, in this case, the exposed group is the group that received the intervention, non-exposed group was the control group. So, each of these rectangles represents the incidence, the risk ratio of the individual studies, the point estimates, and then you have the total cumulative or the pooled relative risk of the entire meta-analysis. The pooled relative risk is represented by the diamond. Again, in this diamond, so the diamond looks like this. The center, the vertical connecting the top and the bottom of this rhombus represent the actual pooled relative risk, and the corners or the ends of the diamonds represent the 95% confidence intervals of the pooled relative risk. So, this means that when you repeat the same study 100 times, 95 out of the 100 times, the pooled relative risk is likely to lie between these two ends. These two ends are called as the lower and the upper confidence interval. So, 95 out of 100 times, the study results or the study's relative risk is likely to lie between the upper and the lower confidence interval, which represents the sort of the maximum likelihood of where the RR is going to lie. So, based on this pooled RR, if you find that this pooled RR is lying completely to one side of this line of null effect. So, this is called as line of equivalence or line of null effect. So, this represents relative risk of 1, which means that there is no difference between the intervention group and the control group. So, if the pooled relative risk or the rhomboid, the diamond, lies completely to one side of this line of null effect, then it means that the study or the meta-analysis found a statistically significant effect of the intervention on the outcome. If by chance the diamond actually crosses this line of null effect, so in this case the diamond is touching this line of null effect, then it means that the intervention does not have a statistically significant effect on the outcome of interest. So, either if your diamond lies completely to the left or completely to the right of this line of null effect, only then it means it has a statistically significant effect on the outcome of interest. So, this 95% confidence interval can be calculated by various, or the pooling can be done by various techniques. You have either the fixed effects model or the random effects model. Fixed effects model is used when the heterogeneity is low or when the studies are fairly homogeneous or similar to each other. Random effects model is used when there is high heterogeneity. So, this particular meta-analysis has used the the mental Hetzel method, and it is using the fixed effects model. So, if you want to understand the heterogeneity between the studies or the differences, variability amongst the studies, you look at the heterogeneity column, and here they would have given something called as a I-square. I-square here is 0%, which means there is hardly any variation between the study. Now, heterogeneity, it is one of the important parameters to watch out for in a meta-analysis. So, heterogeneity refers to the differences between the studies in terms of the population that is studied, that is the characteristics of the individual patients, or the characteristics of the intervention of interest, or the characteristics of the outcome that was being studied. So, for example, if you have studies which are very different from each other, it is like putting apples and oranges together in the same basket and trying to interpret it, which will not be meaningful. For example, if one study included babies which were less than 32 weeks and the average mean gestational age in that study was 30 weeks of gestational age. You had another study which looked at extremely preterm babies between just 26 to 28 weeks and the mean gestational age was 27 weeks in that study. You can't really infer the same result from these two studies because their populations itself were very different. Likewise, one study could have defined NEC as a stage 2 radiological NEC or higher. Another study could have defined NEC as merely the presence of any feeding intolerance or even single episode of vomiting or abdomen distension. Again, we cannot interpret the results meaningfully if the studies have defined the outcome very differently. So, if you have variations between individual studies in terms of the population studied, in terms of the intervention, in terms of the outcome that was being studied, then it becomes a wider heterogeneity, and when you have a heterogeneity defined as I-square more than 60%, then it is better that we use the random effects model rather than fixed effects model. So we've discussed about forest plot. You have the individual studies on the left side, which are represented here. So these are all the individual studies, the years of publication, the intervention arm in each of these studies, the number of patients who develop the outcome in the intervention and then in the control arm. Then you have the point estimates of the relative risks from each of the individual studies represented by the square or the rectangle, and this line representing the 95% confidence interval in each of the studies. So the length of this line is going to be determined by the power of the individual study, which in turn is determined by the sample size. So the smaller the sample size, the wider will be the variation in the relative risk. So wider the variability or wider the standard deviation or 95% confidence interval. Hence the line is going to become longer. Or if you had a very large study or large sample size, then you are going to have greater confidence in the results. So your confidence interval line will become narrower, right? And this vertical line represents a line of equivalence or line of null effect of the intervention on the outcome, and the diamond or the rhombus represents the pooled relative risk of all the RCTs within the meta-analysis. This pooling is merely a summation or average of the relative risk of the individual studies, but it is called as a weighted average. It's called a weighted average because you give weight to the power of the individual studies. So a study with a larger sample size will have more representation in the pooled relative risk. So if the rhombus or the diamond crosses the line of nil effect, then the intervention of interest does not have a meaningful effect on the outcome. So we studied about the pooled or the summary estimate, the line of null effect, and if I square is more than 50%, then there is substantial heterogeneity. More than 75 is considered to be considerable heterogeneity. Now we will move on to the fourth question, which is going to be on diagnostic tests. So we already discussed about the ROC curve. Now we are going to discuss about the other parameters that we normally study in a diagnostic test. So let's go for an example. In a study, the accuracy of C-reactive protein was evaluated against blood culture for diagnosing sepsis. Of 75 neonates, so this is a study on neonatal sepsis. Of 75 neonates with positive CRP. Now CRP, is it the test or is it gold standard? Obviously it is a test because the gold standard is going to be culture. So which means of 75 neonates with test positive, 20 were culture positive, which means 20 were truly deceased. So of 75 test positives, only 20 were truly positive. 5 cultures were positive in 125 neonates with a negative CRP. So 5 were deceased among the 125 neonates which were so-called test negative. So the first step for calculating all these parameters, whenever you get a question on a diagnostic test, please first try to draw the 2 by 2 table. So you will have 2 by 2 table where your columns will always be the true positive, that is deceased, gold standard positive or deceased. So gold standard positive and gold standard negative. So deceased, non-deceased. Here it is like culture positive, culture negative. The horizontal rows are going to be constituted by the test positive and the test negative. So we don't seem to have the total number of newborns in the study given directly to us, but what we do know is that among the 75 neonates who were test positive, which were the CRP positive neonates, only 20 were culture positive. So we do know that this column, this row, this total adds on to 75. So if you add this and this, total test positive, and we also know that 20 of them were the culture positive group, so that is truly positive. So this is 20. And hence remaining will be 75 minus 20, which is 55 here. We also know that 5 cultures were positive in the 125 neonates with negative CRP. So we know that these two again add up to 125. So total number of newborns in the study seems to be 200. 125 plus 75. CRP was negative in 125, CRP was positive in 75. Among those 75 positive CRPs, 20 were actually culture positive, 55 were actually culture negative. Among 125 CRP negative individuals, 5 were culture positive. So this column is 5, this cell is 5. So 125 minus 5, 120 were culture negative and CRP negative. So you have constructed the 2 by 2 table. So this is A, this is B, this is C and D. If you get the 2 by 2 table right, then most of your problem is solved. The rest of it is only calculation of the individual parameters. So say sensitivity. So sensitivity is defined as the number of individuals who tested positive for CRP among the deceased individuals. So the denominator will be total deceased true positive. So which is 25, and among which how many were CRP positive? 20. So 20 out of 25 is 80%. So I'll move on to the next page. So we have made this 2 by 2 table now already. So true positivity or sensitivity is, this is A, B, C and D. So here in this example, this is A, this is B, this is C and D. So true positivity or sensitivity is A by A plus C. A is test positive, A plus C is total deceased. So this column, culture positive. So in this first thing, sensitivity is 20 divided by 20 plus 5, 25 and hence 80%. What is true negativity or specificity? It is nothing but D by B plus D. So here D is 120 and D plus B is 120 plus 55, which is 175, which is 69%. So specificity is 69%. So specificity is slightly lesser than sensitivity. So it's very typical of a test like CRP, which is more sensitive. So it doesn't usually miss babies who are truly deceased, but it can identify babies who are not really having disease also as CRP positive. So that is the bigger problem with CRP. Positive predictive value, a little different. So when you discuss these predictive values, the denominator becomes the test positive and the test negative. That way it is actually more relatable to the real life scenario where you don't actually know the denominator of the true deceased individuals. So we do not know who is deceased. That is why we are doing the diagnostic test. Usually when we do CRP, we don't know the culture results. So, but you might know how many babies turned out to be CRP positive. So that is easier for us to actually tell. So in positive predictive value, the denominator is the CRP, the test positives. So among test positives, how many were truly deceased? So the proportion of the deceased, truly deceased by test positives gives us the positive predictive value. So here, positive predictive value, the equation, the formula would be A by A plus B. A is 20, which is truly deceased, and A plus B, test positives is A plus B, which is 75. 20 by 75 is the positive predictive value. Among 75 newborns with CRP positivity, only 20 were truly deceased. So this is the positive predictive value, which is 27%. Quite low. So CRP actually is known to have poor positive predictive value. So majority of newborns with positive CRP will actually not be having sepsis. CRP comes positive in various non-septic inflammatory conditions. So it has poor positive predictive value. Negative predictive value, on the other hand, is defined as the number of non-deceased individuals out of the test negative babies. So if you have 100 test negative, CRP negative babies, how many of them were actually not deceased? So here in this case, test negative is this column, right? And the true negative is this, 120. So this is B by C plus D. B by C plus D. So it's 120 by 125, which is 96%. So it is an excellent negative predictive value, which means if you get CRP negative, then we have excellent likelihood that the baby is truly not deceased. So it gives us great confidence that the baby doesn't have infection. So CRP is actually a test which must be used more often for its negative predictive value than the positive predictive value, because it has better NPV. So you do not justify a decision to begin an antibiotic based on positive predictive value. You may as well justify that decision based on the clinical signs of sepsis. But you are correct, you are justified in arguing that CRP came negative and hence we did not start antibiotic if the baby is also clinically stable. So this is, I think, a little bit more explanation on sensitivity, specificity, etc., etc. So we'll move on to the next question. Which statistical test is to be used in these different scenarios? This is the next question. So here we are going to discuss about some of the tests of significance. Which test do we use in which scenario? We have different tests like chi-square test, we have simple or student t-test. we have the Mann-Whitney test. So let's discuss a little bit about which are the tests to be used for assessing the significance between two groups. First question, in a RCT, comparing two drugs, paracetamol and brufen for treating PDA, 500 neonates were enrolled. Okay, so you have a randomized control trials in which you have randomized 500 neonates and we are going to compare two drugs for closing PDA. Now, each of these scenarios we are going to identify the test of significance, statistical test that we are going to use. During analysis to compare the gestational age of the two groups, the test to be used is what? And that too they have asked if it is normal distribution and if it is skewed distribution. So question they are asking is gestational age is what kind of variable? Is it a categorical variable like a yes or no variable, or is it a numerical variable? It is obviously a numerical variable. Gestational age is going to be in a number, say 27 weeks, 27 weeks plus 5 days, 28 weeks plus 2 days, 37 weeks plus 6 days, etc., etc. So this is obviously a numerical variable. Next question you have to answer is it a discrete numerical variable or is it a continuous numerical variable? In other words, does it have a decimal point or does it not have a decimal point? Gestational age can have a decimal point. So you can have 37.5 weeks, which is something like 37 weeks and 3 days. Whereas if you have a numerical variable like number of newborns with NEC, you cannot obviously have a numerical variable. You can have either 2 newborns, 20 newborns, 30 newborns, 100 newborns or 0, but you cannot have a decimal point. Whereas gestational age can have decimal point. This is called as a continuous variable. If a numerical variable cannot have a decimal point, it's called a discrete numerical variable. So examples of continuous variables would be like birth weight in grams, hemoglobin of the baby, hematocrit of the baby, serum sodium level, etc., etc. So now if you have a continuous numerical variable, usually we use t-test for comparison. So t-test is used, or simple t-test is used if it is normally distributed, which means in each of the groups, if you plot the gestational age across the data set, the distribution will look like a Gaussian curve or a normal curve. That means it has a mean, it has a bell-shaped curve, it has a mean, it has 1 standard deviation, 2 standard deviations on either side, and equal number of individuals are present above and below the mean. Whereas if you have a skewed distribution, it is going to look like this. So you have the mean might be somewhere here, but you will have the median, which is at the peak of the curve. So you have more number of individuals on one side, like either lower distribution or higher distribution. So then it becomes a non-normal or a skewed distribution. So if you have a skewed distribution, then we use Mann-Whitney test. Okay, student test and the Mann-Whitney test. The next question is to compare the proportion of newborns that received antenatal steroids. What test would you use? Now, proportion of newborns receiving antenatal steroids is a categorical variable, right? It's a yes or no variable. Then we use chi-square test. Okay, so this is about the first part. So just to break this down further, to understand which test of significance is to be used, you need to understand the type of data. So if it's a numerical data or whether it's a categorical data. Again, numerical as we discussed can have decimal point like continuous variable, which is example birth weight, blood pressure, or it might be discrete numerical data which has only finite options like number of doses of steroids or number of individuals with the condition. Categorical variable typically are non-quantitative variables which are available as yes or no variables. They can be again either nominal like a blood group, O positive, A positive, or gender, male, female. Ordinal categorical data will have a hierarchy or an order. For example, severity scale for pain or grading or staging of a tumor, stage 1, 2, 3, 4, etc. So based on the type of variable, we decide the statistical test. So if you're dealing with categorical data, yes or no data, then the usual test that is used for comparison is chi-square test. But again, if it's matched categorical data, then we use something called McNemar test. And if its expected number in one cell is going to be below less than 5, then we use a subtype of chi-square test called as Fisher's exact test. So categorical variables, you always use chi-square test. Usually, and if the expected number in any one cell is less than 5, then we use Fisher's exact test. Whereas when you have continuous data, then we have to see whether it is normally distributed or skewed distributed. Now, if it is more than equal to 2 groups and if it is normally distributed, then we use the student t-test or the simple t-test. If it is skewed, like as we discussed, the distribution is not a Gaussian type distribution. It is not that equal number of individuals are present below or above the mean value. You have, say, more number of individuals on the lower end of distribution or the lesser values than the higher values. Then we call it as a skewed distribution or non-normally distributed numerical data, in which case we have to use Mann-Whitney U-test. When we have matched data, for example, you have some before and after study, same group of individuals were analyzed before the intervention, after the intervention. So this is called as matched data. And if you are comparing some numerical variable within these two groups, matched groups, then we use something called pair t-test. And wherever this numerical data is skewed distribution, we use a Wilcoxon sign rank test in the matched data. If we are, for example, having multiple groups, like 3 groups, let's say in the same study, we were comparing 3 drugs and looking at PDA closure as the outcome. For example, you had paracetamol group, you had brufen group, and you have indomethacin group, or you have a third control arm where we didn't use any drug. Then we have 3 groups, or we can even have 4 groups. So when we have multiple groups, then we don't use t-test. We use something called as ANOVA, which is analysis of variance, when we compare the normally distributed numerical data. Again here, when we are using the non-normally distributed numerical data in 3 groups, we use the Kruskal-Wallis test. So this is about the continuous data. And when we are comparing correlation, like we saw in the scatter plot earlier, then again we have 2 different terminologies. For normally distributed continuous data, we use the Pearson's, and the skewed data, we use Spearman test. You can remember S for S. Skewed data is Spearman test, and normally distributed data we use Pearson's test. Okay, now let's move on to the second segment, which is going to be on fetal medicine, some questions in prenatal ultrasounds and prenatal diagnosis. Okay, so first question is going to be on gestational age assessment. So here you all know that the most reliable trimester for gestational age assessment is the first trimester. The second and trimester can also be used, but the variability is more. So in the last trimester, the variability is as much as 14 to 21 days. Second trimester, it's around 10 to 14 days. Whereas in first trimester, the variation is only around 3 to 5 days for the gestational age assessment. Okay, so till what gestational age the ultrasound is reliable for dating? It's around 22 weeks. Okay, so the parameter that is used for the first trimester scanning is crown rump length, CRL. In the second trimester, usually we look at biparietal diameter or BPD, whereas in the third trimester, usually the femur length is used. And as we already discussed, the CRL is the most sort of precise or reliable, accurate parameter for the dating. Okay, 2 reliable parameters for early pregnancy, and the most reliable parameter in second trimester, best predictor for fetal growth aberrations. Let's see all these answers. So, through 22 weeks of gestation, most genetically normal individuals cluster closely on nomographic curves. So, that's the reason for the reliability for gestational age. You know, in terms of growth or in terms of the assessment of the parameters, it's most reliably done in the first few weeks of gestational age. Beyond that, parameters can depend on the placental state, or the placental insufficiency can actually result in aberration of the growth more and more. So, you know, even if you find, say, something like a abdomen circumference which is lagging in third trimester, it could be because of faltered growth, and hence it cannot be used for assessment of the gestational age. So, the early dating in pregnancy is done mostly on the basis of embryonic pole and on the basis of crown rump length. Biparietal diameter is obtainable after the parietal bone calcification in week 12, and it maintains the closest correlation with gestational age in the second trimester. And in the third trimester, we use the femur length. Next question is on RH isoimmunization. So, this is one of the common conditions that we see, especially given the fact that we have a fair proportion of individuals who are RH negative in blood group. So, every mother should have blood grouping and typing done during the pregnancy, and it is also important to know the blood group of the father. Okay, so you have a O negative primary gravid mother who was referred to for antenatal counseling. Husband is A positive. So, there is a setting for RH isoimmunization. She is a primary mother. You will base your counseling based on the following facts, and let's see these questions. So, what is the overall risk of sensitization in the first pregnancy? So, we all know that RH antibodies are formed during pregnancy because of the sensitization with the D positive cells of the fetus. Antigen positive cells of the fetus may percolate into the maternal circulation because of some degree of fetoplacental bleeding, fetomaternal bleeding, and this will result in sensitization. And usually this happens during labor or in the end of the pregnancy, towards the end of the third trimester. Usually the sensitization chances are less during the first and second trimester, unless there is some procedure like an invasive sampling such as CVS or amniocentesis. So the overall risk of sensitization in the first pregnancy is generally considered to be around 7 to 8%. And the coexistence of ABO incompatibility. So ABO incompatibility, when it coexists with RH isoimmunization. So for example, in this case, the mother is O and the husband is A. So let's say the fetus is also A. Now, to some extent, the fetal cells that come into the maternal circulation will be subjected to the anti-A antibodies also that the mother would have developed. So as she gets sensitized to the RH antigen, she is also getting sensitized to the ABO antigens. So these anti-A antibodies can cause some lysis of the fetal RBCs even before they manage to sensitize the mother with the RH antibodies. Hence, ABO incompatibility in pregnancy is actually protective against RH isoimmunization, and hence this reduces the risk of isoimmunization to around 1 to 2%. So from 7 to 8%, it reduces to 1 to 2% with concurrent ABO incompatibility. So what is the percentage of RH negative mothers who are non-responders? So 30% of the RH negative mothers are considered to be non-responders, that is, they do not develop the antibodies. Now, the greatest risk of isoimmunization, as we discussed, is during the delivery, and it is not prior to that. And we give anti-D to prevent this sensitization, right? So anti-D is generally recommended during pregnancy at around 28 weeks to prevent the sensitization during labor or during the last trimester of pregnancy, and then we once give it postnatal. Postnatally, it should be given within the first 72 hours after birth, so that whatever fetal red blood cells entered maternal circulation during labor or during delivery will be taken care by this anti-D. So 300 micrograms of Rho-RH antibody, RhoGAM, immunoglobulin. So its immunoglobulin is antibody to antibody. So this 30 microgram of RhoGAM or anti-D antibody, in fact it is antibody to the anti-D antibody. This is enough to suppress the immune response of 30 ml of fetal whole blood. This is equivalent to 15 ml of fetal pack cells. So this is the maximum amount of fetal circulation that enters the maternal system during the delivery. The next question is about fetal ventriculomegaly or lateral ventricular dilatation. So Mrs. A, 28-year-old pregnant mother, was referred for antenatal counseling because of lateral ventricular size of 13 mm, and you are being asked to do counseling, and what is going to be your advice to her? Now, is this ventriculomegaly? What is the cutoff? How do you divide it as mild, moderate and severe? Beyond size, what are the parameters that determine whether the prognosis is poor, and what are the other anomalies that can be associated with lateral ventriculomegaly? So this is a very important area for counseling. So lateral ventricular dimension of more than 10 mm at the level of the posterior atria of lateral ventricles is considered to be lateral ventricular dilatation or enlargement. So the cutoff is 10 mm during fetal life. This again is classified as mild, moderate and severe, just like you have the classification in hydronephrosis. Mild refers to 10 to 12 millimeter, which is most of the babies would turn out to have normal prognosis, and less than 5% are going to be abnormal. In moderate lateral ventriculomegaly of 13 to 15 mm, they will have intermediate prognosis, or only around 10% will be abnormal. In severe ventriculomegaly of more than 15 mm size, the prognosis is poor and around 50% will be abnormal. Now, in addition to the lateral ventriculomegaly, we also must remember the association with other intracranial or extracranial abnormalities, and the presence of concurrent chromosomal abnormalities can determine the prognosis. 10% of babies with lateral ventriculomegaly may have chromosomal abnormalities, trisomies, and hence, if you have multiple hard markers, you must consider doing amniocentesis or a CVS to look at the chromosomal diagnosis. That is for karyotyping or for chromosomal microarray. Now, 50% can have associated cerebral or non-cerebral other defects, say like the presence of corpus callosum agenesis. These can make the prognosis even more poor. So, one of the commonest things you should rule out is corpus callosum agenesis. Next question is about prenatal surgery, prenatal intervention for myelomenincocele or MMC. So, there is one study, management of meningomyelocele study or MOMS. It compared open fetal repair at 19 to 26 weeks with conservative approach during pregnancy and only postnatal repair. So what happens if you actually intervene during fetal life itself is the question that it was trying to answer versus waiting and watching. So there were some advantages and there were some disadvantages of this study. So the important benefit was there was a significantly lesser need for VP shunt placement postnatally. So with the prenatal intervention group, it was only 40%, whereas 82% required postnatal intervention or VP shunt postnatally. And there was also some improvement in the motor function defined as ability to walk by 30 months. So 42% in the prenatal intervention group versus 21% in the only postnatal intervention subjected group. And adverse effects were increased incidence of preterm labor, lower mean gestational age at birth, which was around 34 weeks, premature rupture of membranes, which was around 46%, chorioamniotic membrane separation, which was seen in around 26% of babies, placental abruption, and also some risk of fetal demise. So all these complications leading to preterm labor, rupture of membranes, or fetal demise were slightly more common when prenatal intervention was done. But the important advantage was that the survivors had better motor function and also lesser need for VP shunt placement. This next question is going to be on placental examination or findings. So there is a mother who developed PPROM at 28 weeks, and a week later she develops clinical chorioamnionitis and hence taken for cesarean section. Placental histopathology was sent and report is available in 48 hours. So what is a specific microbe that causes the following manifestations? So there are some specific parameters and we are going to discuss where we see these specific changes. So neutrophilic exudates involving villi and intervilli space. This is seen with Listeria monocytogenes. This is a gram-positive organism, and it is the second most common cause for early onset sepsis in the Western literature. Where you see microabscesses on the external surface, you see on with candidal infection. So if you see fungal infection causing placental inflammation, you often see microabscesses. Periarteritis and necrotizing umbilical phlebitis is often seen with syphilis. So if you see a necrotizing phlebitis or funicitis, it's a sign of syphilis. Villus plasma cells are seen with CMV, so nucleated white cells and villus plasma cells. Stromal necrosis and calcification are often seen with herpes simplex, and umbilical cord pseudocysts. Pseudocyst itself is a sign that you see with toxoplasmosis. So this is a sign of toxoplasmosis. Toxoplasmosis is one infection where you end up giving spiramycin during early pregnancy, and later in pregnancy if it is diagnosed, the other drug of choice is pyrimethamine sulfadiazine. Because it can cause more fetal effects, we prefer to give spiramycin whenever toxoplasmosis is proven in early pregnancy. So I think that finishes the presentation today. So we will catch up with more OSCEs